Hello, today on Pharmacology Fundamentals, we will be discussing anti-hypertensives, which are a drug class aimed at reducing hypertension. So buckle in, ladies and gentlemen, because we will be answering all your questions on why anti-hypertensives are needed, what they do, and how they work. Hypertension, also known as high blood pressure, is a common disease whereby the pressure of blood flow exerted upon the arteries of the body is higher than normal blood pressure levels. To fully understand antihypertensives, we must first look at the physiology underlying hypertension. So let's start at the beginning. The heart has four chambers. The right atrium and ventricle pump blood to the lungs to be oxygenated. This is pulmonary circulation. The left atrium and left ventricle pump oxygenated blood to the rest of the organs and tissues in the body, systemic circulation. Arteries transport blood to the tissues. The pressure exerted on arterial walls is known as blood pressure. Systemic arterial blood pressure is the blood pressure within the large arteries involved in systemic circulation. Hypertension is the persistent elevation of this systemic arterial blood pressure above normal levels. Hypertension is diagnosed using systolic and diastolic blood pressure readings. Systolic readings are the maximum pressure recorded after aortic ejection of the left ventricle, whilst diastolic readings measure blood pressure between heartbeats. An ideal reading is 120/80. However, a reading of 140/90 or higher classifies an individual as having hypertension. Hypertension may be broken down into two categories, primary or secondary. Primary hypertension is diagnosed when there is no obvious secondary cause and is often a result of genetic and lifestyle factors, such as age, high sodium or low potassium diet, and degree of physical activity. Primary hypertension accounts for 95% of hypertension in adults, so it is likely you have been diagnosed with this form. Secondary hypertension, on the other hand, occurs as a result of underlying medical conditions. Some diseases that cause secondary hypertension include primary aldosteronism, renovascular disease, and drug or alcohol use problems. The principal determinants of high blood pressure are cardiac output and peripheral resistance. These factors are the targets of antihypertensive drugs. Cardiac output is the volume of blood the heart pumps out per minute and is dependent on stroke volume and heart rate. Thus, cardiac output affects blood pressure as greater blood volume in the arteries increases the pressure exerted on vessel walls. Blood pressure is also influenced by peripheral resistance. This refers to the resistance generated by the arteries that opposes the direction of blood flow, thus creating pressure within the blood vessel. Arterioles, which are small branches of an artery, are the site of peripheral resistance. Arterioles are lined by smooth muscle cells. This enables them to either contract or dilate, thus influencing peripheral resistance. In a normal functioning body, blood pressure is regulated in several ways. The circulatory system regulates blood pressure by employing the sympathetic nervous system. When blood pressure is low, this triggers the release of neurotransmitters norepinephrine and epinephrine. These cause vasoconstriction of both arteries and arterioles, which increases vascular resistance, thereby increasing blood pressure. When blood pressure is too high, the arterial stretch triggers bioreceptors that line the arteries to signal the decrease in sympathetic activity and reduce the production of norepinephrine to decrease blood pressure. Increased sensitivity to norepinephrine and dysfunction of bioreceptors has been linked with hypertension. Endothelial cells also contribute to blood pressure through the release of various vasoactive factors. Vasoactive factors control the contraction or dilation of blood vessels. In hypertension, the endothelial production of these vasodilators and vasoconstrictors is disrupted, with reduced synthesis of nitric oxide, a potent vasodilator, contributing to high blood pressure. The kidneys also play a role in responding to long-term changes in blood pressure and blood flow. They do this by secreting hormones that regulate blood volume. Dysregulation of kidney processes, specifically the excretion and retention of sodium, are characteristics of hypertension. High concentrations of sodium and low levels of potassium promotes fluid retention in the kidneys and the blood plasma, thereby increasing blood volume and consequently blood pressure. Dysregulation of peripheral resistance is linked with hypertension. The sympathetic nervous system, endothelial cells, and the renin-angiotensin-aldosterone pathway collectively regulate it. In hypertensive individuals, this dysregulation leads to increased vasoconstriction of arterioles. Over time, the persistent muscle exertion can create lasting structural changes, thickening of the walls and narrowing of the arterioles. Overall, this increases resistance to the blood, leaving the arteries, causing a pressure buildup. Additionally, reduced arterial elasticity plays a fundamental role in hypertension. As we age, the elasticity of artery tissues decreases, causing greater stiffness and increasing blood pressure. Thus, as people age, the risk of hypertension increases. Left untreated, hypertension can cause heart attacks, strokes, aneurysms, and heart failure, as well as secondary conditions such as atherosclerosis. Atherosclerosis is a disease caused by high blood pressure, in which damage to vessel walls causes them to become clogged with fatty plaque and permanently narrowed. So as you can see, it is imperative to reduce blood pressure in patients suffering from hypertension, and this is where antihypertensives come in. As I mentioned earlier, antihypertensives are drugs that have the therapeutic intention of preventing, controlling, or treating hypertension. There are several broad classes of antihypertensives that reduce blood pressure in different ways. Vasodilators reduce blood pressure by dilating blood vessels to decrease peripheral resistance. Diuretics work to promote sodium and water removal by the kidneys to reduce blood volume and thus blood pressure. Others work by decreasing cardiac output by reducing heart rate or contractility and thereby reducing blood pressure. The simple acronym ABCD can be used to remember the most commonly prescribed antihypertensives: ACE inhibitors, beta blockers, calcium channels, and diuretics. Today we will delve into ACE inhibitors, which are one of the most commonly prescribed classes of antihypertensives. ACE stands for angiotensin-converting enzyme. ACE inhibitors reduce blood pressure by acting on the renin-angiotensin-aldosterone pathway. Normally, this pathway works to increase blood pressure in response to low sodium levels or a drop in blood pressure detected by the kidneys. This is achieved by the release of renin, a molecule which enters blood circulation and converts the liver hormone angiotensin into angiotensin-1. This is where ACE comes in. ACE is produced by the cells lining the lung and the renal system. ACE binds to angiotensin-1 and catalyzes its conversion into angiotensin-2, which now has specific surface proteins, allowing it to activate one of two G protein-coupled receptors, the AT1 and AT2. This initiates bodily processes that increase blood volume and peripheral resistance in order to increase blood pressure. In patients with hypertension, this process must be inhibited in order to lower blood pressure. As the name suggests, ACE inhibitors work by preventing the function of the angiotensin-converting enzyme. ACE inhibitors have a specific chemical structure that binds to a zinc component of ACE, thereby preventing it from functioning. Without ACE, the conversion of angiotensin-1 to angiotensin-2 does not occur. Preventing the production of angiotensin-2 reduces blood pressure by inhibiting the release of vasoconstrictors by the endothelial cells, preventing arterial contraction, thereby decreasing peripheral resistance. It also inhibits renal tubule stimulation. This decreases sodium reabsorption by the body, prevents the adrenal cortex from releasing aldosterone, thereby encouraging sodium excretion. Remember that lower sodium concentration reduces fluid retention, thus reducing blood volume and decreasing blood pressure. There are many different ACE inhibitors, and your doctor will choose the drug most appropriate for your condition. They differ depending on the zinc component they bind to. The most commonly used ACE inhibitor is lisinopril, often branded as Zestril. Its zinc interacting mechanism is a decarboxylate group. There are several possible side effects of the ACE inhibitor lisinopril, which are shown in the diagram. Some more serious consequences associated with its use include hypotension, an increase in potassium levels, which can lead to an irregular heartbeat and renal failure, the formation of angioedemas, which are fluid-filled tissue cavities in the deepest layer of the skin. If these occur in the tongue, glottis, or larynx, they can cause airway obstruction. Anaphylactoid reactions or non-immune rejection reactions to the drug, renal failure, particularly when taken with direct renin inhibitor. So who can take ACE inhibitors? Patients under 55 have higher levels of renin compared to those over 55 and those of African heritage, and will therefore benefit more from ACE inhibitors. The higher levels of renin mean that ACE inhibitors have a stronger influence on the renin-angiotensin-aldosterone pathway, and therefore ACE inhibitors are an effective intervention. ACE inhibitors are not safe for individuals with a history of angioedema, carotid artery stenosis, or for pregnant women. This is due to the risk of renal failure and increased blood potassium levels, both of which can result in death or deformity of the newborn. If you have primary hypertension, it is important to pair these drugs with lifestyle changes to ensure lasting and meaningful results. This includes quitting smoking, changing your diet to avoid high sodium foods, and increasing potassium intake, weight loss and increased physical activity, and reducing alcohol consumption. Treating hypertension can be a complicated process. It is important to consult your doctor, who will know what works best for you, but here is a simple guide to common treatment plans for hypertension. So, step 1. How old are you and what's your ethnicity? If you're under 55, you're most likely to be prescribed an ACE inhibitor such as lisinopril. You'll take it orally as a tablet every day. The initial dose recommended is 2.5 milligrams per day, with a maximum daily dosage of 40 milligrams. But if you're allergic to ACE inhibitors, thinking about getting pregnant, or have increased sympathetic nervous system sensitivity, it is most likely you will be prescribed beta blockers. If you're over 55 or of African ancestry, you'll be prescribed a calcium channel blocker. Step 2. If your hypertension is resistant to medication, both ACE inhibitors and calcium channel blockers can be combined and dosages can be adjusted. Step 3. If elevated blood pressure persists, your doctor will likely recommend the addition of a diuretic to your regime. Step 4. If your hypertension is continually resistant to medication, your doctor may prescribe a fourth drug, further increase your dosage, or refer you to a specialist for treatments such as renal sympathetic denervation. We hope this video has helped you understand antihypertensives. Join us next time on Pharmacology Fundamentals.